We have Dr. Stephen Longenecker, who's the medical director for the Joint Care Center at the Reading Hospital. We also have Kenneth McAlpin, who's the medical director of the Hip Fracture Program. So a little bio on Dr. Longenecker. He's a Berks County native. He went to Albright College, Temple University School of Medicine, did a residency in orthopedics at Temple, and then a fellowship in adult reconstructive surgery at New England Baptist Hospital. His office is the Bone and Joint Care Center, and again, he's the medical director at the Reading Hospital for the Joint Care Center. Next up is Dr. McAlpin. He's a Florida native from Tallahassee. He went to Haverford College, Florida State University College of Medicine, did an orthopedic residency at the Boston University, and a Boston University fellowship in adult reconstruction. His office is also the Bone and Joint Care Center, and he's the medical director of the Hip Fracture Program at Reading Hospital. So some of our accreditations, we have our advanced certification in hip and knee surgery. We also have a 5-star rating from Health Grades, and we're in America's top 100 hospitals. Our mission statement is to provide quality care using best practices to the adult population seeking to have elective hip or knee replacement surgery from the preoperative phase and beyond to discharge. For the format for the presentation, we have Dr. Longenecker, who will be going over anatomy of the knee and hip, arthritis and joint pain, conservative treatments and prevention, and injuries and prevention. Dr. McAlpin will be going over knee replacement approaches and techniques, hip replacement approaches and techniques, and the operative fracture repair. Afterwards, it will be followed by a Q&A session.
Jordan didn't have the rest of this bio, but again, I'm privileged to be here. Love the support that our program has from our community, and very blessed to have introduced my family. My son, Stephen, is with us here, and you know him from different roles, but I know him as the office manager at our office, and the guy I can go to and say, hey, I need to get someone in the office, or I need some more time off, or things. But his wife, Rebecca, and then three of my granddaughters, Ava's the oldest, Ellie, and Edie. I don't have a pointer, but my daughter Mary is there. She's in New York now. My wife Lisa, that many of you know, and my son Andrew came back to Reading about 2 years ago in anesthesia, and we have a granddaughter with his wife Maggie, and that's Marie, and the newest addition, just about 1-year-old Roger, and there's some people that might know his namesake. So there we go. Oh, there you go. So I'll start our conversation about joint replacement and arthritis, but I do want to give a special thanks. Jordan didn't introduce herself, but she's been with our program for a number of years. I'll get it wrong, but she just took over. Lynn Burkett, if you've been here before with us a couple years ago, Lynn Burkett was our program coordinator, and Jordan has done a lot of work with us in the OR. But now Jordan has a heavy lifting to make sure, when she mentioned those certifications, that's through the work of the hospital and making sure that we follow current practices. And now we're getting out into community outreach. So that is Jordan. And I want to thank Lisa and Meredith. They're the marketing team from Reading, and also thank Cameron and Jared for helping coordinate this event. So I'll talk a little bit about the anatomy and the reasons for arthritis, and then turn it over to my partner Kenny. The knee is a hinge joint made of the thigh bone, the femur, and the tibia, the lower bone, And the kneecap is the smallest of the bone of the joint, but that's responsible. Some people will come in just with kneecap arthritis, and that's responsible especially for the going up and down steps and the pain in the front of the knee. There are ligaments in the knee. The outside ligaments are the collateral ligaments, and the cruciate ligaments are inside the knee. The hip is a different joint, and that's why people recovering from hip replacement experience different therapies and different activities than knees. The hip is simply a ball and socket joint. So again, we as surgeons can reproduce the hip joint very well. When Kenny talks to you about the socket, that'll be the acetabulum, and the ball is the femoral head. The causes of knee pain, certainly there are injuries, the football injuries, the meniscus and ligament catching in your knee, but the things that we see are arthritis, and typically broken down into rheumatoid throughout your whole body, many joints, or osteo, just wear and tear. Same causes of arthritis same cause of pain in the hip, rheumatoid osteoarthritis, but there are some unique aspects of the hip. The ball and socket, you can be born with a misshapen socket. So women with dysplasia can be predisposed to early arthritis. Men, a type of impinging arthritis. And there's also a fast-acting arthritis called necrosis because people lose the blood supply. I'll show you examples later. But basically, the arthritis means you're losing the cartilage. And so on this diagram, little by little, from left to right, people get their bones closer to bone, closer to the point of being bone on bone. In our practice, we want to treat people from the beginning stages to the end stages, but I don't always put people on a scale and say, if you have a little bit of arthritis, you can never have surgery, or if you have a lot of arthritis, you always need surgery. We usually will start with the simple things first. And our academy has very strong guidelines recommending natural supplements, anti-inflammatories like Advil or Aleve, or painkillers and rarely narcotics. If you're not getting relief with the simple things, certainly the next step is to inject. You can get a lot more bang for your buck. You can be a lot safer by putting medicine that you need right in the joint rather than throughout your whole body. So cortisone injection might work 6 weeks or 10 weeks, and that will temporarily reduce the swelling and inflammation. Hyaluronic acid is a popular intervention. It's a series of 3. It's to lubricate the joint. It doesn't work as quickly as cortisone will, and our experience is our academy will publish that if you are bone on bone, well then lubricating bone on bone doesn't really help. But in the earlier stages of arthritis, hyaluronic acid is a good option. What a lot of people still are coming to us, and I just read an article to make sure this is current, but just read an article last night reviewing that our academy still will be hopeful for regenerative. Regenerative would mean we would put platelet-rich plasma, something that will stimulate your body to put cartilage back on the joint. But the reality is, once you're bone on bone, the structural damage is too much and it doesn't help. I think we'll find that we'll still engage and we'll still research, but until it's FDA approved, until it's studied, until it's successful, the other downside of regenerative medicine is it's not usually paid for. So people might go to a symposium, people will say, well, we'll come down, but then they're down getting these injections that may or may not work, at tune of $500 to $1,000. So our academy really doesn't find that appropriate use at this stage, but more to hope on that. What I always tell people, and again, every now and then I'll have a patient that will say, Steve, whatever it takes, use my name, tell them about my hip. And Luther Routine, my pastor, many of you, he says, Steve, use my name all the time. I can remember the day when I told him, Luther, I looked at your x-rays, it's coming, you're going to need surgery soon. And he said, Steve, no, I've been doing exercises and look at my quads and I'm stronger now. And he literally got worse on the x-ray, but develop less pain. And I think that's, really a key message about arthritis is exercise. And you have great facilities here and great people that can train you. And if you get outside and walk the community. I think that's helpful. Or my mom goes to Body Zone. She lets me use her name too. So I saw she took these pictures. They have a fitness challenge. Usually for the knee, the exercise is anything for the quadriceps. So leg lifts, mini squats. That's going to be the thing you can do. Occasionally, especially if it's temporary, we'll find success with using braces. Where I find it's most helpful, again, here we are talking about the kneecap, that the bone that you feel in the front of your knee. Sometimes that kneecap can shift or slide, and until you get your muscles strong to keep the kneecap aligned, sometimes a simple knee sleeve will help. Again, our diagnosis usually is with medical history, physical exam, x-rays, and occasionally MRI scans. And if we're thinking about arthritis in multi-dimensions like rheumatoid, blood tests. Now I'll move on to the hip a little bit and talk about the hip. The hip is a little bit more deceiving for me than the knee. The knee, people touch it. They know where their knee is. I can usually feel the grinding. If there's fluid in the knee, people know they have fluid in their knee, water in the knee. But the hip, people will come in and they'll say, my hip hurts. Some of them are pointing to the back. Some of them are pointing to the outside, the muscles, the bursa. And some of them, are really pointing to the groin, the joint. So the hip, it could be an overlap of symptoms between the muscle, the back, and the bursa. I often will use an injection in the hip less to give you relief, and I've had people literally that I'll give them a knee injection and they'll be good for 6 months. The hip injection isn't as good, but what it does do is help me decide whether the cause is the hip joint. If the arthritis isn't evident on the x-ray and the injection works even for a day or 3, Ken and I will do those injections in the x-ray room, see that it goes in the right spot, and if you call back in 2 weeks and it's better, we know that's where the pain comes from. Again, I'll mention the types of arthritis, run-of-the-mill osteoarthritis. There is a little bit more concern with the hip than the knee, that if you're wearing away the socket, they'll call that protrusio. Men who are younger can have a misshapen ball, that would be called impingement. A condition called necrosis might not show up in the plain x-ray, but an MRI scan. And that's a condition unique to the hip joint where the circulation is disrupted, and that can be rapid. You can see on the right, the ball is round, but on the left, that person had necrosis. She was a resident here, and here in a matter of 3 months, her hip socket, her hip ball wore out because of necrosis. Dysplasia, again, we're picking that up better now. Children, when their hips are loose, the pediatricians are great at finding dysplasia and then putting the sockets in so they don't get arthritis. But if you have undiagnosed abnormal shape to the socket, you'll develop dysplasia. Next, I'll talk briefly about hip fractures and pelvic fractures. Again, I see a lot of canes and walkers. Don't throw them away. Use them, especially as the weather gets bad. A very common thing, and again, so common that since our program in joint replacement was strong, Dr. Barbera felt we should have such a strong program in hip fractures so that we have consistency of care, and Ken was appointed the director of that. Hip fractures, when people fall, they can break the pelvis, just the ring, and that usually doesn't require surgery. They can break higher on the ball, and again, with that poor circulation, that ball could be slow to heal, so we'll do a replacement. But lower in the ball, we'll need pinning, and Kenny will go over that. As far as prevention, again, all I can keep saying is stay active. When your son invites you to go out and go up to the barn and mow the lawn, go ahead and do it. Put down your other activities. You can come and play mahjong later. Stay active. My dad, I tell this story a lot. My dad, when we would go up there, this is Ava and our wood pile. I moved into the meadow, so I don't have a wood burning stove, but Andrew does and Kenny does, so I still chop wood up there. But my dad would stand there and push the lever down, and he'd be on one foot. And I said, Dad, what are you doing? Did you have a pain? He said, nope, I'm working on my balance. And he was always good at working on balance. And again, there are some exercises that you can do. Ashley is our nurse, and she's been with us for longer than I can say, but she helped me with this slide because she just did a paper on fall prevention. And some of it's the stuff around your home, remove boxes, remove clutter. Don't be afraid to install grab bars and things. There are so many people that, that tell us a story when Kenny and I see them after they broke their hip. Well, I just was going to the bathroom and but it was dark and I lost my balance. So, make sure your lighting's right. But the second thing is, like my dad said, it doesn't hurt if you're holding on to something, work on your balance. My mother-in-law, Edith Skornowaki, she'd say she'd work on her brain with crossword puzzles, but my dad said he'd always work on his balance. I trained at Temple under Dr. John Lockman, and a very famous person, but he was also a strict character, and he made us all read, and I trained in the 80s, and he made us all read this 1956 article by Walter Blount. He was a famous surgeon, and it was called "Don't Throw Away the Cane." And again, John Lockman was right, because in the Journal of Bone and Joint Surgery in 2003, they republished the same article. And basically it was saying that when you're standing, you're putting a lot of pressure on your hip and knee, sometimes 4 or 5 times body weight. He did all the calculations. Just the use of a cane, might offset that. So in addition to taking balance, although it's not fashionable, in this article, he talks about people back in the 50s were starting to wear glasses because it's fashionable, but no one thought it was fashionable to have a cane. I've seen some pretty fancy canes for my patients, and I'd encourage you to keep using them. So at this point, I'm going to turn it over to Kenny, and he'll talk to you about the surgery that we have, and he can introduce his family.
Hello. Okay. Thanks a lot, Steve. And again, my name's Ken McAlpin. This is my family. My wife is Jennifer, and then we have 4 children, 2 daughters and 2 sons. Madeline's our oldest with me, and then the next one, Gabriella, and then our 2 boys, Kenneth III, and then Thomas. And then I just want to reiterate, Dr. Longenecker went over a lot of good information and gave you all a lot of information. And most of the time people come to see us, they're going to be dealing with the information you already got. The majority of people with arthritis are able to be treated with non-operative means. And it's only very few people that the arthritis progresses to a point where it's affecting their life at a level where they will need surgery. But if it does come to that, there's always the question of when is it time for surgery? And so when I'm talking to my patients, and I know Dr. Longenecker does this too, there's 2 main questions I tell people to ask themselves. Is the pain in your joint decreasing your ability to do things? And is the pain in your joint affecting your quality of life? And if those are 2 questions that you can say yes to, then it may be time to start thinking about surgery. The other more serious thing would be is if there's so much deformity in the bone that it's becoming unsafe to walk or move around. There are a lot of surgical options for arthritis and problems with the joints, and we'll go over these briefly. The first one, the simplest surgery that's really only available for knees, would be knee arthroscopy, or the common term for this is a knee scope. And that uses small incisions, a camera, and some small instruments to go into the knee, look around, see what problems there are, and then treat minor problems. Knee scopes are best for problems with the soft tissue, like the meniscus, which is the bumper between the knee. They're not great for arthritis, but they can be helpful at times for smoothing out some bad portions of the arthritis. There is arthroscopy for the hip, but at this point, that really isn't used for arthritic hips. Arthroscopy of the hip at this point is really for sports injuries. Osteotomies were used. They're very rare these days. So sometimes if there's a physical problem with the way the joint is aligned, we can cut the bone in a way to realign the bone so that the joint has more equal forces about it. Again, this is fairly rare these days, and usually save for people in their 20s or 30s where a joint replacement may not last them as long. So we do bony work instead. Dr. Longenecker already went over the anatomy of the knee, but what I just want to focus on is that for us, when we're talking about surgery or the problem with the knee, we really split it up into 3 areas. When we're looking at the knee from the front, we look at the inside or the medial compartment of the knee, the outside or the lateral compartment of the knee, and then that area where the kneecap rubs, which is the patellofemoral compartment. And so depending on where the arthritis is or where the injury is, there may be other treatment options. And one of those options that's very good, especially for people as they get older, would be a partial knee replacement. Partial knee replacements are really good if there's only injury or arthritis in the knee in one of those 3 compartments. Once we start seeing damage or arthritis in 2 or of 3 of the compartments or all of the compartments, it's really not a good idea to do a partial knee replacement. There are some other things that need to be there and intact in order for a partial knee replacement to work correctly. But partial knee replacement is a very good option for people with arthritis. And here's just some examples of partial knee replacement. So over here, you can see on the x-ray, on the far left-hand side for you, there's an x-ray and there's some narrowing on the inner part of the knee compared to the outer side. And so a lot of times to check to make sure there's not extra damage in the knee, we will get an MRI. And on the MRI, you can see the blue arrow points to an area of white in the bone, and that white is bone bruise. Once we see that on the MRI, it's usually impossible to bring the bone back to health. That's deeper damage that usually will only get better with surgery. And so here, this person did have a knee scope because there was a pretty big meniscus tear, and we can see that there's bare bone in that knee scope image, and that's pointed to by that blue arrow up at the top. The white just below that is the healthy cartilage. So this patient had a partial knee replacement, which you can see on the x-ray is the bright white, that's the metal, and we've increased that space and we've actually straightened the leg out so that the kinematics, the physics of the knee are back to a more normal level. Here's just another quick example, same thing. The x-ray on your left shows narrowing on the inner part of the knee. We got an MRI. This is just a different color scheme where there's a dark patch that also shows that bruising of the bone. And then here's this person's partial knee replacement. So just in review of partial, this is a very good alternative for people that have isolated arthritis in one of those 3 compartments. The nice thing about it is it's about half the recovery of a total knee replacement, also half of the overall pain that you deal with going through surgery. Partial knee replacement does leave people with a more natural feeling knee because we leave all of the ligaments and tendons that are normally there. And if the partial knee were to wear out over time, the surgery to fix that is much easier. It's going from a partial to a standard knee replacement, as opposed to if you have a regular knee replacement and that wears out, then we're talking about a redo knee replacement, which can be much more complex and complicated. So here are examples of times when it would not be a good idea to do a partial knee replacement. So in these x-rays, you can see that there's a lot of deformity in the knee, as well as absolutely no space. And there's also damage to the other side of the knee too. And when we look at total arthritis of the knee, there's 3 main ways that our knees wear out. The most common is on the far left, and that's called varus, or a bow-legged deformity. And that's where the inner part of the knee has the majority of the wear, but there's also wear in the other 2 areas of the knee. Least common would be a valgus deformity or a knock knee deformity, where the outer portion of the knee is the worst. And then very rarely it wears absolutely evenly, so both sides are as bad as each other. And when we see that sort of thing, that's when we recommend total knee replacement. And there's a couple different ways to do total knee replacement. There's different ways to get into the knee. And for a long time, we did what was called manual knee replacement, where we used 2-dimensional x-rays to measure how we would reconstruct the knee and then do the knee replacement that way. And then more currently, we've started using robotics, which uses a 3D image, usually a CT scan, to do our planning. And then this is just another example of a partial knee replacement. here's just, again, some examples of knee replacement versus partial, what they actually look like. And then here's the incision that would come from partial versus total. So on your left, the patient's right knee, that you can see that's a slightly smaller incision from the partial knee replacement versus the opposite knee, which is the longer incision from the total knee replacement. Like I was talking about, there's robotic assisted. For a while, we were doing what was called computer assisted, and that sounds very similar, but there's a slight difference. Computer assisted, we were still planning with two-dimensional images, but we were using computers to help us accurately determine how much bone we were removing for the knee replacement. This is an example of what the computer navigation setup looked like when we were using that. Another option is something called shape-fit technology or patient-specific instrumentation. So this does use three-dimensional imaging, either CT or MRI. What this does, though, is it makes personalized what are called cutting blocks, which is the white plastic piece that's on the knee right there. That would be a one-off, fit exactly to the patient, and then use that to make the specific cuts to then reconstruct the knee. This is still available today with different companies to do it this way. But the newer technology is with robotics, specifically with Mako total knee replacement, which is what we're currently using at Reading Hospital. And so a lot of questions I get about the Mako robotics is, well, where are you? Is the robot performing the surgery? Is it possible that it's going to get upset and attack me? And no, so this is exactly what the robot looks like. It's just a robotic arm with a saw attached to it. The robot does not turn the saw on or off. We still turn it on and off, and it does not move. We still move the robot. What this does is it locks the saw in place in the precise position in order to cut the bone and reconstruct the knee. This is an example of reconstruction of a knee using the robotic platform. So this patient, if you look at the x-ray on the left, they had a crooked knee with a knock knee deformity, so valgus, and then using the robotics and the 3D imaging, we were able to reconstruct it to a straight knee that you can see on the x-ray on the right. Just to go over this a little more, so this is how we did manual knee replacement with something called cutting blocks. So like I showed you with the patient specific, it was a white cutting block because that's 3D printed, a one-off for a specific patient. Whereas with standard manual knee replacement, we use metal cutting guides that we reuse. They had dials on them. So once we took your x-ray and measured your angles and know how much bone we needed to take, we would dial those into these cutting blocks. And then we would use a freehand saw to then make those cuts. And this was very good. We've had very good results with knee replacement using manual, but not quite as good as hip replacement, which is why we kept trying to get knee replacement a little bit better, which has brought us to robotics. And so here's the plan for a robotic knee replacement where we use the 3D imaging, and you can see those 3D images there, which help us get a better fit and just overall better accuracy for our surgery. These are just some examples of Dr. Longenecker and I performing the robotic knee replacement. And then on the far right, that's just the setup that we use, the leg holder, how we set up the knee before we do the surgery. While we're in there, the other big advantage to the robotics is that we get feedback as to the tightness or the looseness of the ligaments that hold the knee together, which we never had before doing manual knee replacement. And what we found is that if we measure those beforehand and then we try to recreate those as best as possible, that gives people a more natural, more normal feeling knee than if we don't measure those. And so we use these spoons that are different thicknesses to measure the gaps in between the bones to help reconstruct those back to what was normal and what you currently lived with. And so here's just an example of us using the spoons during a surgery to measure the tightness of those ligaments. So here's just another example of a robotic knee replacement before and after. So on to hip replacement. Our operative technique for total hip replacement has been fairly similar throughout the years. Like Dr. Longenecker said, the hip itself is a ball and socket joint, which is a much simpler joint than the knee. And so there's two main parts to this, the ball and the socket. The ball, or the acetabulum, is made of a cup and a liner that goes into the pelvis, and then the ball is attached to a stem that goes into the thigh bone or the femur. We also use three-dimensional imaging sometimes with hip replacement, especially as they get more complex, to better understand the anatomy and make sure that we can reconstruct the hip back to as normal as possible. Here's an example of one of those patients, like Dr. Longenecker showed, that had some dysplasia and had some shallow socket, and then their new hip replacement, which recreated their anatomy and actually brought their leg back to even compared to their other one. There's a smaller procedure called hip resurfacing, where you don't take out as much bone. That was used more commonly about 10 to 15 years ago. And in order to do this sort of surgery, we have to use a metal on metal bearing, where the ball is metal and it rubs on a metal socket. And what we found is if that the socket and the ball are not in the exact perfect position, there can be wear of that metal, which releases metal ions into the body. And if those ions get to a too high of a level, can end up causing problems. So in very specific circumstances, hip resurfacing is still used, but it's very rare today. As far as how to do the total hip replacement, there's three main ways that we can get into the hip in order to do hip replacement. And a lot of people ask questions about this. One of the more common ways is called the anterior lateral or lateral approach. That involves an incision on the side of the hip, and we go in through the side in order to get down to the hip joint itself. Probably the workhorse for a long time since the start of hip replacement was the posterior approach, where we went in through the back. For a while there was minimally invasive 2 incision, where we made one small one in the front and one small one in the back. And today we prefer the direct anterior approach, or often referred to as the Smith-Peterson approach. The reason we like this one is we don't have to cut any tendons, we don't have to split any muscles. We use the natural planes that were already there from the muscle to get down to the hip. We use a special table to do the surgery, which allows us to be more efficient. And this also allows us to use x-ray. With the anterior approach, we do the surgery while you're laying on your back. With the other 2 approaches, we have to do it while you're laying on the side. This is an example of that HANA table and the setup that we use in the operating room. This is a live sample, so this table is very useful in letting us maneuver the hip very precisely so that we can do this surgery as efficiently as possible. While we're doing the surgery, we also use computer assistance and robotic technology in order to make sure that the implants that we put in there are positioned as precisely as possible. So here we're looking at the socket part. Through a lot of research, we know the parameters that this should be in there to give the best possible outcome, and so we measure this with every case that we do. There's a difference in the bearings that we use, or the articulation where the ball meets the socket. The most common one that we use is a metal on plastic socket. More recently, we've started using a ceramicized metal on plastic because that seems to last a little bit longer. In the past, we've used, like I talked about, a metal on metal, which we've sort of gone away from, and very rarely we'll use a ceramic on ceramic metal liner. As far as outcomes for total hip replacement, they're very good. Patient satisfaction after hip replacement is 98%. And you can see here, there's very little complications, and there's long longevity for hip replacement. Going on to fractures, like Dr. Longenecker said, there's a couple different places where the hip can fracture. There's 3 main areas we look at. We look at if the ball is fractured, if the neck, the transition from the ball to the femur itself is fractured, or if the femur is fractured, known as the intertrochanteric region. So for a full fracture through the neck part, which disrupts that blood supply like Dr. Longenecker was talking about, the best option is hip replacement, which you can see here. If there's a fracture in that neck region, but it's not fully fractured and the pieces are not apart, we can sometimes save the bone and do what's called open reduction internal fixation with 3 screws. And that way the bone heals on its own, and we're able to save any bone stock this works well if people don't have pre-existing arthritis. The final type of hip fracture is where it's further down the neck into the actual femoral bone itself, and that's called a peritrochanteric fracture, and those are best treated with some sort of nail or intramedullary device, where there's a rod that goes down the middle of the bone and then a larger screw that goes across the neck into that ball part of the bone. And then, you're talking about.
Yep. So again, thank you for thank you again for having us. What we did is we put some pens and papers out there. I'll tell you just a thing or two about the Reading Hospital Joint Center and our program, and then Jessica's going to come up and talk a little bit about the rehab opportunities here. I did mention when I was talking to her that I'm surprised how many people have their surgeries, right here at Reading, but have great experience coming right back to their own home. And over the 30 years, I mean, people used to all be in rehab, and now there's more and more people that can recover in their own environment. It's really nice that you have such a great facility. I also think that we're fortunate in Reading. I had someone from Rothman, Pete Sharkey, come visit right after this opened. Charlie Sullivan met with us, and they were only going to build 5 floors, but we met and he made a wise choice to build the 6th floor. And so we have a dedicated joint replacement unit on the 5th floor of the Joint Center. And again, there are private rooms. The environment is nice. The physical therapy therapists have a gym that gets you to practice going in and out of a car, steps, bathrooms. The Healthplex was built 2016 or so. And again, that was just another advancement that our hospital made, because it really brought up to speed all the safety, the sizing, and the cleanliness that was required. And again, as Dr. McAlpin was pointing out, there's more and more technologies. I mean, when I think back of doing those surgeries in the C building, now that we have robots and computers and things like that, you just wouldn't have fit them in, but for the spacious rooms and again, clean air and all the cleanliness that's required. Again, one of the things that I pointed out that I really can only be thankful for and be a part of, but not responsible. I'm not the one that started this whole thing. The program has really made joint replacement in our community safe. Jordan, on a monthly basis, meets with a whole team of people. And when we have a question, when we see people with, I think I saw on your list for next month that we're talking to the urologist and talking to someone with nutrition, we try to get people in the best shape that they can, making sure they don't have any tendency toward carrying infection. We ask our diabetics to get the diabetes under control. And through these efforts over the years, we're recognized then by reviewers. Healthgrades is a national organization, and they recognize this in 2023. Will be recognized as 5-star facility for knee replacements and 5-star for hip replacements. We also go through certification. So every year we meet with the reviewers, and they ask us questions. What are you doing? What's your next program initiative? And then every other year, we actually have reviewers on site. And I think Jordan put these slides together. We had hip and knee certification starting in 2011. And then we went to advanced certification. They not only look at our surgery hospitalization and see what we're doing there, make sure it's consistent, safe, and high quality, but they also look at before and after surgery. And we have gone through advanced certification now 3 times. Jordan helped us with the 2022, and we're one of only 10 in this whole state that shows advanced certification. So we have a great team, and it takes a team to deliver this kind of care. And I'm blessed to be part of the bone and joint care team, and we want to thank you again and offer any questions. Do you want to come up and go over things? These are some, it's amazing. Patients send us photos of what they're doing afterwards. We're really lucky. This guy was really at base camp of Mount Everest and a parachute jumper. I'm not sure I recommend that. So.
Hello. Good. The Highlands at Why I'm Missing is happy to welcome back the Tower Health going and joint team. I'm so happy that we've had such a great turnout today. I know you all missed the active aging seminars that they had here, so hopefully we can have them back in the future. Just to kind of wrap up, after you have an elective surgery, if you're planning a surgery, please remember, it's always a great idea to contact me. My name again is Jessica King. I'm the clinical liaison here at the Highlands, and I am a resource for you when you're having surgery and to help with your discharge planning after your hospitalization. Dr. Longenecker did mention that a lot of people will have surgery though and recover back at home. So we do have options to help support you here at the Highlands for outpatient therapy services. It's also great for continuity of care. The same folks from Heritage Health Pro that service our rehabilitation unit also act as our outpatient therapy team as well. So regardless of what your need is post-surgery, here at the Highlands, we can support you back in your apartment, or if you do have a need for rehabilitation, we can meet that need here in our 18-unit private room, dedicated rehabilitation unit. So again, I encourage you, contact me so that we can discuss your insurance coverage and that transition so that you have all of your questions answered prior to your surgical experience.
Well, thank you. And then Jordan will take, if you have any questions, you want to write them down, Ashley will collect them, and if not, enjoy the rest of your day. And we'll stick around afterwards too if you have any questions.
One question was childhood deformities. Is this a population that you're seeing later on for joint replacement surgeries?
Usually, if it's a childhood deformity like what we were talking about, the most common ones, acetabular dysplasia. And I think, you might be able to talk about this too, Dr. Longer, but I think usually most of the time we'll start seeing that in the 40s or 50s. There's rare cases where it's very slight dysplasia, and that may be why you're having arthritis, but the really severe dysplasia cases, usually that'll start showing up somewhere in when people are in their 40s or 50s. Do you have any?
No, I think.
Yeah.
Another question was, what is the approximate time frame towards relief from pain? I think this is related to surgery.
So whenever I'm talking to someone about surgery and we're talking about when pain is going to be relieved, there are so many factors that go into that. With hip replacement, I think you'll agree it's a little bit more
Pretty quick.
Yeah. And depending on how bad the problem is before we fix it, that can determine how quickly relief is. Sometimes when we see patients with very, very bad arthritis where the bone is almost fused together, those people get almost immediate relief after surgery, where they actually leave the hospital having less pain than they did coming in. Sometimes when there's less deformity or there's other areas of pain that are involved, pain relief can be a little bit longer. I'd say with hip replacement, maybe the average that I tell people is to expect to have most of your pain gone by 6 to 8 weeks. Do you agree?
Yeah, and the other thing people ask is, how long is recovery? And it's sort of like Ken said, well, are you saying how long before you feel any bit better or how long before you're completely relieved? When we're talking about recovery, I tell people that the recovery is a day, a month, 3 months, and a year, meaning most of our patients, and now we're about 10%, Jordan knows the national numbers, but in Florida, there are places where 50% of the joint replacement patients, ours are about 10%, will leave the hospital the same day they came in. So now they have a lot of support and they have home care and things like that, but most of our patients will come in, and again, since you're all prepped and ready and you have good health, they'll usually come in the morning on one day and go home in the afternoon the next day. So the recovery hospitalization is one day. I tell people to mark out about a month where you're really dedicated, because our knee patients, you have to get 90 degrees of bend. Your hip patients, the hip replacements are usually done without cement. So even though you might feel good because your hip is bone on bone, I usually want people about a month where you're letting those muscles that were split but not cut sort of heal. Let about a month for it to grow in. And for your knee patients, about a month where you're really working hard in therapy. Usually people at a month are back to walking with a cane, pretty active, driving. But as far as planning big trips and going out and 2 rounds of golf or whatever, a lot of back to work for our younger people, 3 months. And then we always tell people come back at 3 months, say, well, there's still a little bit of this, there's still a little of that. It takes about a year for full recovery. So maybe that helps questions about recovery as well.
Yeah, I would just add knee replacement is a little bit slower than hip replacement. And there's 2 main factors with why that is with knee replacement. And number one is because there's not as much muscle that covers the knee. I'm sure all of us can go down and feel your kneecap. There's not that much skin and soft tissue that's between the outside of the skin and the bone. And so because of that, there's not as many blood vessels and there's not as much nutrient that gets to the knee as quickly as the hip. The other thing is everybody scars and swells differently. And one day with us finally mapping the human genome, we'll probably figure out what in people, their DNA or their genes causes them to have more scar or more swelling than someone else. But at this point, we just don't have that information. So we don't know who are heavy scar formers or who are very large swellers are going to be until after surgery, unfortunately. So if you are one of those people that does form more scar with surgery, or you do swell more if you have injuries or surgery, your recovery is going to be a little bit longer than someone who doesn't have those things.
Are there any more questions out there?
Actually, there's a couple. Yeah, take
I just
them.
want to take the mic.
Take them, but there's also one. Actually, there's 1 or 2 people.
I'm sure I can. I work with
Just turn it on.
Did you hear that? She said she can read any writing. She worked with me. I actually don't write anymore. We type. We're all electronic. And I had a pharmacist who said that was the biggest thing advanced. He's just retired from Penn, from downtown Penn, and he said that was the biggest advancement. So, Dr. Malik, you were there when we turned into electronic, right? Dr. Malik is responsible for getting rid of doctors' handwriting.
One of the questions was, why do some people limp after hip replacement surgery? Is it a leg length discrepancy?
No, it's because Kenny or I didn't do the surgery. No, I'm teasing.
Again, that that can be from multiple different reasons. Sometimes it's the approach. So like I talked about, there's 3 different ways to get into the hip. One of them, the lateral approach, is it's much more common to have a limp in the early phase after surgery. And the reason for that is because for that one, you do have to remove one of the large tendons off of the bone in order to get in from that side view. So that could potentially be a reason. The other reason, leg length discrepancy can go into that sometimes. The other thing is, depending on how bad the arthritis is or what the cause of needing the hip replacement is, there could also be muscle damage. And so with the joint replacement, we don't touch the muscle. There's really no way to repair muscle or rebuild the muscle from surgery. So all we're really doing is changing the bone, the way the joint is able to move. The muscles still have to get better. So I know you've had plenty of patients, and I have, where the arthritis has gotten so bad where the joint just doesn't move anymore. It's almost fused. It's locked in place. And when that happens, the muscles can no longer function. And so you have to think about it. If you're not using a muscle for a really long time, you can't just expect once the joint's able to move that the muscle is going to magically get better. You have to work on it, like Dr. Longenecker said. That's why a lot of times we have people go to therapy beforehand and afterwards to build that muscle strength back up. Because a lot of times those muscles that help support the hip, now that it's moving and it has free range, there's no other stability because that bone was causing the stability, but we removed that so that it could start moving. So now the muscles have to do extra work to help it stay in place. And so that's where people can have a limp or some differences in their walking for a while after they're recovering from hip replacement.
I gave you a question.
So this question is, how, where, and when did you learn to do robotic surgery? So I think our experiences might be a little bit different. I trained with some robotic surgery stuff in my training. And then on top of that, you also take courses to become accredited in your robotic surgery. And so there's a certain number of hours you have to meet training with the platform, using it, and then you go from there. Again, the robotics isn't so much, it's not a different surgery. It's all the same stuff we did. It's just using technology to make it more accurate. So there's not really a difference as far as what we're doing, manual versus robotic. It's just in how accurate we're able to do those things and the steps we're taking in doing that.
But I would agree. The enjoyable thing, again, I feel myself blessed, fortunate to have had a career that expands and work in such a neat community. But as much as those manufacturers make a lot of money and have big billboards, they really do help us with training. So and the other thing is, requirements of medical officers like Dr. Malik saying, well, you can't come and do this unless you get training. And actually young partners who inspire us to go. So we actually, I didn't know anything about robotics when I went through my training, but Ken already knew he was going to come to Reading. Reading supported our program and saying, okay, if you guys get trained and you think it's worthwhile. And so then we visited surgeons in New Jersey, Mary Ann Yoder and I think Jordan, you visited a lot of times. We did a lot of visits to other places to see how they do. They let us scrub in, and then we'd come back and she'd report to her higher ups and say, yeah, I think that's a good program. And then Ken and I both flew to Florida, I guess, to get our certification. You do cadaver labs and things. So it's an extensive training. And then again, the nice thing, when we started together, mm-hmm. and we would do a lot of cases together, and then we would only do certain cases. But I think now with the hip, I'm just about 100%. Kenny does all the big heavy lifting, the revisions and things like that. So he'll do those through the lateral approach. But with the hips, we're about 100%. We're doing them direct anterior, and for the knees, we're about 100% robotics. Whereas in the beginning, we were just doing it little by little, but we've been doing it long enough that we really feel comfortable with the technology.
Oh, let's reach that.
I used to be 5'11", and now I'm 5'9". Can you help me get those 2 inches back? Yeah, some of that is true with the bow-legged, and then like Kenny showed you, a little bit taller. But I think most of the publications on loss of height are from the spine. I smile because my dad's somewhere watching, but I'm pretty sure my dad had an inversion table. Mom, did Dad have one of those things that hangs down? So maybe an inversion table. So I don't know if you recommend that or not.
I don't think we have one on campus. The question was, there was a friend who had a primary knee replacement and then a robotic knee replacement, and the pain experience was different, and they felt more burning pain with the robotic surgery. Can that be explained?
Whenever someone has surgery on one knee or one hip and then the other one of the PAs that works with us has a great saying, and his saying is, the knees or the hips, they're brothers or sisters, they're not twins.
Yeah, Dan Hawkins says that. We work with great people. Jessica Ertel, Dr. Ertel's daughter, and Dan Hawkins, a Fleetwood guy. And he's great. That's a good one.
I know you've done this longer than me, but I've been trying to figure out how we can figure out which one's going to be the worst one, which one's going to be the easier one. And every time I think I have it, I have a new patient and it's flipped. And I try my hardest to give people as much information as they can going into surgery. And for whatever reason, sometimes the body doesn't comply, and one side's a lot harder than the other. And a lot of times we just don't know why. I had a recent patient that had very bad knees. We did one knee replacement, flew through that one, did the second one, and the knee just got so stiff. And they were having a lot of problems bending it. And then we did a quick thing to help them bend, and it's like perfect, just like the other one, but nothing was changed. They didn't take any different medication. We didn't do the surgery differently. As far as the x-rays in it, everything looked very similar, and there's no rhyme or reason to it sometimes. But doing great now.
Burning is sometimes nerve, and I'll mention that Stephen's, I don't know if he's still here, but Stephen and Ken were working on this, and we always are trying to improve. The robotic is a little bit less invasive, but burning, Ken and Jessica have learned a technique where you can actually affect the nerves, and then they're starting, maybe in another year or so it'll be more consistent, but there is a technique of cryotherapy where you can actually, maybe Ken can mention that.
Yeah, so we use a device that freezes the nerves, and it's been shown that if we do that before knee replacement, that it will help with some of those problems like the burning pain, the nerve pain, and stuff like that. And a lot of studies have shown that if we do that procedure before, it greatly reduces the amount of pain medication needed after surgery also. So
always improving, trying to. Thank you.
Yes, thank you, everyone. Thank you for having us.
Yep, thanks very much.